¿Qué se ve en YouTube? ¿A nuestro Samsung o directamente este?
Nothing, the camera.
Es que está muy manchado desde...
Yes, great. So we cannot say bad words.
Live? Alive already?
Yes, we're live,
Yes.
we're live, we're live, we're live, we're live, we're live. Go, 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 go.
Okay, good morning.
Can you shut
good
up?
Morning.
Because we're gonna start. Come on, audience.
Good morning, everybody. Good morning to all of you here. Good morning to all in YouTube Live. It is an honor to share the stage with my dear colleague and friend André today. We are going to discuss a little bit the dichotomy Endo versus implant to see if we discuss or not. Maybe we don't discuss so much. I'm going to fight for the Endo team. But first of all, the Endo team cannot fight if the restoration is not possible. So, before everything, the main fighter is the prosthodontics. If the rehabilitation, the periodontology don't go well, the endodontic treatment, it's no need because nobody wants an endodontic treatment. People want a tooth with which, or teeth with which they can chew, they can do their normal function. And this has been stated for many years and for all the academies. This is a diagram for the American Endodontics Association. And they begin by discussing prognosis by the tooth structure, the possibility of crown lengthening, and only in the end, they go to the prognosis of the endodontic treatment. And we are going to see why. And showing up a little bit why, it's because the prognosis of the endodontic treatment, if well performed, is really good. So everything else before, it's where many times it fails. That's why it is so important to diagnosis, and that's why it is so important to know literature before taking decisions. And literature by the end of the 90s were very poor regarding prognosis of endodontic treatment. And so in the last decade of 1990, was designed a study. It was meant to be a prospective study, trying to control or to seek in pre, intraoperative, and postoperative everything that could affect the prognosis of endodontic treatment. And it was stated as the Toronto project. Many articles were published. It was a study that was made retrospectively in college by university students, but even though everything was done by the best standard of evidence by the time. What does this mean? This means that first treatments that were recorded that were in 1993 did not have the same techniques of preparation, of obturation that we have today, because they were changing with time. In endodontics, many things have been changing with time, but rubber dam has always been used. Disinfectant solutions, proper disinfectant solutions, proper disinfection times were always used. So what we know that for endodontics is the most important thing, that is removing bacteria, has always been kept in mind and has always been managed to achieve. And so articles were published divided by 3 stages for initial endodontic treatment, orthogrid retreatment, and apical surgery. In initial retreatment, so when we have a decay, a pulpitis, when we have a trauma, anything that leaves us to do the initial treatment of endodontics, 4 articles were published. And something very important that showed up in the first one in 2003 is that the definition of healed, meaning that we have a teeth with periodontal tissues healthy and clinically healthy. Healing, the tooth that we have that did not have periodontal tissues healthy by the beginning of the treatment, but that now has a reduction in the apical lesion size, and clinical normal, and functional. And functional is the pool of healed plus healing plus the ones that we don't look at the x-ray or we don't give importance to the x-ray as long as it is clinically functional. This is very important because this leads us to the discussion of success or survival. So success is when we have healed or healing. Survival is the functional. The tooth is in mouth and it is okay, functional. I'm going to go through the studies very fast. just to say that the techniques were changing, the sample was growing larger because they had a very large dropout in the first 2 studies, so they pulled all the number of cases. But by the end, what seemed to be very important for prognosis was the presence of previous apical periodontitis, complications like instrument separations, perforations, and the question of the number of roots. Multiradicular tooth seemed to have a lower prognosis by 15%, but this has to be seen with care. Why? Because they always looked for the tooth with the worst root, so the roots that had the larger apical lesion, that had the complication. If they looked individually to each root, maybe this would not be so true. So mainly presence of apical periodontitis and complications during treatment. Anyway, we are dealing with 88% of success rate and 95% of survival rate. For retreatment, in those cases that our initial treatment fails, here they only published 2 studies. It is very important to notice that in the first study, MTA was not used because it was not available, or it was not so much spread at the time. And what seemed to be constant was presence of apical periodontitis. So again, in endodontics, the presence of apical periodontitis seems to lower our prognosis. And what seemed to be very relevant was the presence of perforations. Here, for the first time, we are dealing with a success rate of lower than 15%, 50%. And we know that the prognosis of perforations since the end of the 90s depends a lot on time, when did the perforation happen. And we must think that when we are dealing with a retreatment, we are dealing with an old treatment. So if the perforation is old, that lowers a lot the prognosis. Location, in cervical it is worse because of the bacterial colonization, and the size. The worse the perforation is, the larger the perforation is, the worse the prognosis is. And in some one we cannot save the teeth because we have perforations, decay, everything. In some apical, we can seal the perforation with MTA and we can have a good prognosis. So, in sum, the retreatment as prognosis, what does it depend on? Apical periodontitis, the same as initial treatment. Complications, here specifically the presence of a perforation, and the quality of the previous root filling. Before speaking about the quality of the previous root filling, I'm just going to ask you to pay attention because we are dealing with prognosis again. Success rate over 80%, survival rate over 90%. It was thought many years ago that poorly root-filled canals should not be retreated. Nowadays we know that it doesn't affect so much a treatment because poorly root-filled canals many times mean that the canal is there, that it is not treated, that bacteria remain because disinfection was poor, the root canal was not prepared. So it is possible to retreat poorly, it is possible and it is desirable to treat poorly root-filled canals as well. This was a patient that came to me because she was in pain in the upper right maxillary. And she went to another dentist who started the treatment of tooth 17. I don't know how it was before. She came to me in pain and she told me, it's the same, it's the same. What do I do? Do I need to extract them? What do I do? I know I have the one with the root canal filling. They tell me it doesn't hurt. They tell me it's this one, but the pain is the same. What did I tell her? You have a success rate of almost 90%. You have a survival rate for these teeth of over 90%. So let's retreat the 16 and let's finish the retreatment in 17. And she's asymptomatic for something like 2 years and well. About apical surgery. Apical surgery in endodontics and in surgery as well has been very studied, many studies, everything published. And what is important to know is that things changed a lot with the introduction of ultrasonics, microscopes, and mostly and everything together with MTA. I'm not going to speak about any of these surgeries, or any of these articles. Some of these are from the Toronto project. I'm going to show a study that it's from 2 years ago from a Portuguese group in Coimbra. And what they saw was that the presence of bioceramics materials, MTA, was very important for the success of apical surgery, and the success rates reaches again 80 to 90%, almost 80 to 90% success, with survival rates reaching almost 100%. And that some of the potential risk factors are like smoking habits, tooth location and type, interproximal bone level, so factors that are common with implant surgery placement. Surgical prognosis factors, not specifically endodontic factors. With all of this, I'm going to pass the word to André, just leaving these charts that I'm not going to discuss. It's mainly just to show the amount of things we need to know for a proper diagnosis, and after the diagnosis, what we can do. But the most important thing, it's always the diagnosis. It's always to know what we are dealing with and what can we offer and what can we say to our patients. Because by the end, with the proper diagnosis, the treatment has very good success rates.
Bravo, 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 bravo. No, and I agree completely with Teresa. I mean, first of all, welcome to all the viewers at home. For me, it's a pleasure, again, after some years, debating again the endo dichotomy and implant dichotomy. Like I was telling Teresa, I did these sort of lectures for years in the academia, in private associations. And there is no right and wrong decision here. And there is no dichotomy in real life. There's dichotomy in academia because, you know, you have to have some subjects to speak about. But when we are in real life, we normally don't speak about these things because we have a patient that needs endodontic treatment, and it's an endodontic treatment until proven the other way. And even the retreatments, you know, it's retreatment until, you know, Teresa cannot go any further. And like Teresa stated, there are multiple factors that influence the decision to remove a teeth or to stay with a tooth. But let me remind you one thing, you know, implant dentistry didn't come to be in this dichotomy. The implant dentistry was born to substitute missing teeth, you know, and the endodontic treatment is to save teeth that are in the mouth. So it's a completely different approach. So we are not together in this. We are separate therapies. We just only found a common ground when we have to decide if a tooth should stay and then be replaced by an implant, or if it should stay and rehabilitated with the crown. So we are working together on this. We are not working apart, okay? There's the patient that is the most important thing, and we have to make a decision. And normally the decision, like Teresa said, is multidisciplinary. I mean, the first of all that Teresa said is the prosthodontic. And obviously you have to incorporate the tooth in a holistic way, meaning what's the importance of these tooth to the mouth? Is it going to be a bridge? Is it going to be a single tooth? Is it going to be some heroism to try to stay the tooth because he has a removable provisional and he only has one tooth in the back to serve as an anchor? We had a patient that I did an endodontic treatment on this patient that had only one tooth 12 years ago. It's a mobile tooth endoperial lesion, but it was the only tooth that she had, you know, to hold the prosthesis. And we did it because it's the only way. So there's no dichotomy here. Either you treat it or you extract it. And obviously the most important thing is the prosthodontic part. We ask Joao, can you save the tooth? And if Joao says yes, but it has to be a truly yes, because these guys from Prosto, they want to save everything. They only see crown and bridge, and they see if they have 2 millimeters. Oh, no, we can place a crown in here. It has to be a fair decision. It doesn't mean that you have to save every tooth. But, you know, in a decent and very academic and professional way, you have to say if this tooth is going to be saved. If Joao says, it's not going to be safe, I cannot do nothing here, so there's no discussion. It's extraction, okay? Then it comes to me. But if Joao says, okay, we can save this, and so go. I'm out. I'm going to take a coffee, I'm going to run through the avenue, and that's it. So there are a lot of factors that influence this decision, when the tooth is on the borderline. So when Joao says the tooth is restorable, then the dichotomy starts, because we have to make a decision towards the future of this patient. And it is funny because the best friend of the endodontist is the implantologist. It's amazing because sometimes Teresa wants to extract the tooth and I have to refrain. I have to say, no, you have to save these tooth. Even if Joao doesn't have the possibility, you really have to save these tooth. And why? Because implant dentistry has limitations, okay? There are a lot of limitations. We are much better now than we used a few years ago, but there are a lot of limitations. And one of the first articles that I published with Georgia, Georgia just came out from NYU, he did endodontics, I did implant dentistry. And we were always fighting against who's the better discipline. So we decided to put up an article that, that put all the decisions factors in the aesthetic zone. When should you go for, in a tooth that has, it's not clear the prognosis, what are the factors that you should look for? And, what I found out is that I'm always trying to save the tooth because I know the limitations of implant dentistry. And the limitations in implant dentistry in the aesthetic area comes to be with this slide over here. And this is a pretty obvious slide why a tooth should be saved. Because you have something in the tooth that you don't have on an implant. It is called the supracrestal fibers. You know, the supracrestal fibers on a tooth, they have an adhesion to the cement. You know, they come here, they adhere, and they come out to sustain the interproximal papilla and the soft tissue around the tooth. And by having this adhesion, you have a periodontius that is normally higher than with an implant, okay? The other thing is that whenever you have an implant next to a tooth, the interproximal papilla would always be dictated by the tooth, by the periodontal ligament and the interproximal bone. So that means if I have to replace, for example, these tooth over here, my decision is probably take out the tooth and place an implant, because I know my interproximal position will stay the same, will not vary. But for example, if my tooth is going to make a defect of 2 implants together, I know that we'll have a shallow papilla because I don't have the supracrestal fibers, nor I have the periodontal apparatus. I mean, this is going to have a soft tissue defect. If it's on a premolar, nothing happens. But it's from the central to lateral incisor, that's a problem. So whenever I see a tooth that has to be extracted and I cannot hold this interproximal bone on the aesthetic area, then it's the time where Teresa should save the tooth, and then we go with either orthodontic extrusion or elongation, coronal elongation with the periodontist, and we have to put all of this in the table, because the implant cannot sustain this interproximal papilla, which is very important. It's not important in a low smile area, it's not important on an 8-year-old lady, but it's important, for example, in a 25-year-old lady with a high smile line, okay? So this is a case where you probably want to preserve. We are much better now with this. We have new materials, biomaterials, ceramics, and everything, but we will never have an adhesion of the supracrestal fibers. Never. It will only be an adhesion maximum. The tissue is there collapsing. Because the supracrestal fibers here on an implant, they are circular. And here, they are perpendicular. You know, they hold the papilla. Okay, that is very important. And so cases like this, where you have two implants here, this is an easy case. Okay, it's an easy case. It's an easy case. Why? Because if you have a poor prognosis tooth in here and you don't have feral prosthodontic position, the decision to extract the tooth is easier because you have the supracrestal apparatus of adjacent tooth, the supracrestal apparatus of the canine, and you know that you will have a good papilla formation. So it will be an aesthetic case ever. When you reach this area here, the only prognosis that you are fighting with is the peri-implant complications throughout the years. But it's an aesthetic and pleasant situation. You see here, there's no, I mean, you cannot, if I show this, you cannot say that these are fake teeth, okay? And it has nothing to do with the fact that the implant is so good. It has to be with respecting the biology, placing the implant in the 3D position, and then just let the biology fill the rest, okay? This is easily a 90% survival success rate over 10 years. So the thing here that I try to avoid is this, when you have adjacent implants. When you have adjacent implants, then is where your problems start, okay? Because you will have a shallow papilla here. If it's in the midline, you maybe can get away with this because, you know, you just close the contact point. These are a little more square, and you can get away with this. But if this defect is on a lateral position, then people compare the symmetry between left and right, you're in a bad day there because you will have a shallow papilla here and you cannot close with a quadrangular tooth. So that means that if I have this problem in the aesthetic area and I have a hopeless tooth, then you better do everything that's on your side to save the tooth because you can give a proper aesthetic to this area. Then this is very important. That's why I'm saying I'm always the best friend of the endo, of the teeth, because in these aesthetic areas, you need to be careful evaluating those factors. And see, the prosto cannot have a fairly good papilla here. In the midline, you close a little bit this. Gets kind of a little tricky, but you cannot have more than this. By the way, this is not a papilla. It doesn't have the interproximal bone. So it's more a pontic configuration type of style where you squeeze in the tissue to have a papilla there. So here is the problem. Here is the problem. Two adjacent implants on a lateral position. This is a huge aesthetic problem. Huge aesthetic problem. It's the worst nightmare when you end up with teeth like this. Because the interproximal bone just doesn't exist, okay? And you have a soft tissue defect. This is the type of case where, for example, you have a central incisor that we are following on this dichotomy. Try everything to save the tooth. Try everything. It's orthodontic extrusion, it's surgical elongation, it's whatever you want to be sure that we don't fall down on this problem over here, okay? So this is particularly different in other sides of the mouth. For example, if I have a hopeless tooth on the first premolar, then I will probably extract the tooth because, you know, the canine eminence, you know, it holds very good that tissue and no one is looking for the premolar. So actually, there's here a dichotomy. This is the hard cases where you really have to discuss. You know, the easy cases are the premolars, okay? And so these are the case, for example, that you need extra disciplines, like the orthodontist. We have the orthodontist in here in the room. Hello, are you okay? Okay, I'm André. Nice to meet you. Okay, she's the best orthodontist in the world, Dr. Elena. And you know, this is a case where you have an implant, okay, and you have the implant is on this one, and you have loss of insertion of this implant. So this is a problem because you had, you know, bone resorption here that created an apicalization of the papilla, and now you have a soft tissue defect. So what you have to do here is orthodontic extrusion, okay? So don't be afraid of using, you know, strategies other than the implants or the endodontics to save these teeth. And the orthodontic extrusion is one of them, which is very important. So the idea of endo versus implants will always be a multidisciplinary task. Always, always. That on the aesthetic area, you should use it. Don't look to the statistics. Just try to save the tooth. Don't look to the statistics. Don't look to the statistics of retrograde, endodontic, apical. Just do it because of the supracrustal apparatus of these teeth, okay, in the aesthetic area, if you're in trouble. Think 10 times before you extract the tooth on the aesthetic zone, because you can fall down on that or on that soft tissue defect of the papilla, and it will be a nightmare. So from the implant part, there is no dichotomy. You should try to save the tooth, but no heroisms, because that's the other part. You know, sometimes what I see is that you want to save the tooth at all costs, and it's not valid because you're not respecting also the other side of implant dentistry that has, you know, good survival rates. So in the aesthetic area, I think you should do everything with heroisms to save you if you're going to fall down on this situation. But for example, in other areas, it's easier to extract the tooth and place an implant. So the take-home message here is that in the academy, I think there's a big discussion because they're sitting on the room. But on the field of action, there's almost no discussion. We understand each other, and mainly the decisions of the tooth to stay or go is from the prosthodontic side. It's not even us. So I want to thank you to be here with Teresa.
Thank you.
And hopefully we'll continue next week with another seminar. It was a pleasure to discuss with you, Teresa.
Let's discuss.